Hello, everyone. I hope you're doing well. This is Okiraku-Radiology. Let's take a look at another case today. First, I'm going to run through the images quickly. So, were you able to figure out where the lesion is in this case? If you'd like to scroll through the images yourself, just like in a clinical setting, please check out the trial link in the description. All right, let's interpret the images together. The area of concern on today's images isn't so much, "This spot looks suspicious," but rather that the entire small intestine is puffed up. Inside the small intestine, we see gray signals. And on CT, something that looks gray is water. Since we're dealing with the intestinal tract, that means fluid or digestive juices. You'll also notice some areas that look pitch black, and on CT, something that looks black is air. Because we're inside the intestines, air means bowel gas. When the small intestine becomes markedly dilated over a wide region like this, and intestinal fluid or gas collects inside, that is ileus. This time, let's look at images of this ileus. First off, what sort of condition is ileus exactly? Let's imagine it while looking at a diagram of the digestive tract. In short, ileus is a state in which contents accumulate inside the intestine, causing it to dilate markedly. Most cases involve the small intestine, but there is also large bowel ileus. So, when exactly does the small intestine become distended and taut? This is simple. When intestinal fluid, gas, food, and so on cannot flow and remain stagnant in the small intestine, it gradually becomes distended. The causes of failure of the intestinal contents to flow can be broadly divided into two categories. One is the small intestine does not undergo peristalsis. The other is the small intestine is physically obstructed. Let me explain the first cause. The small intestine does not undergo peristalsis. The human digestive tract is like a single passage running from the mouth to the anus. And organs like the small intestine perform peristalsis to move food along bit by bit. However, when abdominal pain is severe or the general condition is poor, the small intestine can lose energy and halt peristalsis. When it doesn't move, the contents stagnate, leading to an ileus state. The second cause is that the small intestine is physically obstructed. This illustration shows the intestine being physically blocked for various reasons. When the pathway is physically occluded, the inside cannot pass and is forced to stagnate, causing the small intestine to dilate. Strictly speaking, when the cause is obstruction of the intestine, this is not ileus, but rather intestinal obstruction. Between the two causes, which one is more serious? By far, physical obstruction of the small intestine, intestinal obstruction, is more dangerous. That's because an ileus caused simply by the intestine not moving due to lack of energy usually resolves on its own. And if that lack of energy is due to another condition such as enteritis, treatment of that condition often leads to recovery from the ileus as well. In contrast, with intestinal obstruction, the intestine is being crushed, trapped, or physically blocked for some reason, so in most cases it won't resolve without surgical intervention. Therefore, it rarely improves if left alone, and it becomes a dangerous situation requiring surgery. Now, let's look at the CT images again. Overall, the small intestine is markedly dilated, and intestinal fluid and gas are accumulating inside. Focus on the state of that fluid and gas. While an excessive amount of intestinal fluid or gas itself is an abnormal finding, something else I'd like you to notice is the positional relationship between the fluid and the air. For example, if we look at the duodenum, which is part of the same digestive tract, we can see intestinal fluid and gas as well, but in this region they appear to be mixed together. On the other hand, how do the fluid and gas appear in this portion of the small intestine? They are completely separated, with fluid and air existing distinctly. This finding is called a nivo, and it is essentially synonymous with ileus. Normally, the digestive tract is constantly wriggling due to peristalsis, so the digestive fluids and gas inside don't separate out neatly. Instead, they mix, ripple, and appear disorganized. But in ileus, the intestine is not moving at all. So the fluid and air remain motionless and simply separate neatly under gravity. In other words, this niveau is proof that the intestine has stopped moving. Now, let's place images of the normal small intestine and of ileus side by side in coronal view, which is the orientation seen from the front, and compare them. In the normal small intestine, there is no dilation at all. It's collapsed. Because it isn't distended, it's impossible to trace the entire small intestine. It expands and contracts in places, but that's because the small intestine is constantly moving. That's just how it appeared at that moment. If you took another image a minute later, it would look different again. On the other hand, the small intestine in ileus is distended everywhere. Because it is obstructed somewhere, digestive fluid and gas accumulate inside, causing it to balloon outward. The intestine is weak and not moving much, which is why you can see signs like a niveau that indicate lack of movement. So, after identifying the ileus, what should we look for next? Next, we identify the site of obstruction. How do we find where it's blocked? This is a tedious process of scrolling through the images and meticulously tracing the intestine. We won't go through every frame in this video, but we would keep scrolling like this while following the intestine carefully. Normally, it's hard to track the small intestine this way, but when ileus causes it to dilate, tracking it becomes possible. Let's start around this area where the niveau is prominent and track toward the right. Then, what do we find? Here, the small intestine's dilation ends abruptly, and it suddenly becomes narrow. That means this is the transition point where obstruction occurs. This kind of imaging feature, where the small intestine suddenly narrows, is reminiscent of a bird's beak, so it's called the beak sign. In this case, the small intestine is obstructed at this spot, so the proximal portion, the part closer to the mouth, remains dilated. If we had been tracking the intestine in the opposite direction, we would eventually reach the mouth. You can experience an ileus case yourself by freely scrolling through the images on the viewer site linked in the description, so please try it out. Now, let's take it up a notch. It's great if you can identify intestinal obstruction, but let's look for additional findings. If you're aiming for the next level, you'll want to classify intestinal obstruction in more detail to form a clearer image. Please take a look at this diagram. It's a classification chart of intestinal obstruction and ileus caused by various mechanisms. As we discussed, functional failure of intestinal motility leading to dilatation is called ileus, while physical blockage causing dilatation is called intestinal obstruction. Physical obstruction can be further divided into simple or strangulated, depending on the presence or absence of impaired blood flow to the intestine. Take a look at this diagram. Intestinal obstruction caused by physical blockage comes in various forms depending on how the obstruction occurs. Some obstructions are caused simply by an internal foreign body or localized narrowing, while others result from complex entanglement or twisting. The differences in how these obstructions occur affect the blood flow to the small intestine. What exactly is intestinal ischemia? Take a look at this illustration. This is a diagram showing how blood is supplied to the small intestine. Inside the abdomen, a curtain-like mesentery filled with fat and blood vessels hangs down, and the small intestine is wrapped inside it, receiving nutrients through those blood vessels. You could say it's like sausages vacuum sealed in a pack. The vacuum pack is the mesentery, and the small intestine is wrapped inside. Because the small intestine is an organ, blood normally flows through its wall to deliver nutrients and oxygen, enabling the intestine to perform digestion, absorption, and peristalsis day in and day out. Now take a look at this illustration that shows blood flow to the intestinal wall during intestinal obstruction. On the left is simple obstruction caused by local adhesions narrowing the small intestine, and on the right is strangulated obstruction caused when the small intestine slips into a tight space and cannot get out. These are scenarios where obstruction happens, but consider, for example, a simple obstruction like the one on the left. Even though the intestine is blocked and contents can't pass, which is serious, what about the blood flow? Although there is an intraluminal blockage, the blood vessels in the intestinal wall aren't being constricted, so blood continues to reach the wall. Therefore, the small intestine doesn't become necrotic or perforate. The risk to life is low. On the other hand, what about the strangulated obstruction on the right? Strangulated obstruction occurs when the intestine gets tangled or trapped in a narrow space and can't escape. In this illustration, the small intestine has slipped into a tight gap and cannot get out. Of course, the intestinal lumen is narrowed, causing a passage obstruction that makes the intestine distend into ileus. But beyond that, if you look at the blood flow situation in a strangulated obstruction, can you visualize that not only the small intestine, but also the blood vessels supplying it are caught together, causing both the intestine and vessels to be crushed and the blood flow to stop? Since the blood vessels are being compressed in that tight space, blood cannot reach the intestinal wall on the trapped side, meaning that side of the wall receives no blood supply. In strangulated obstruction, then, the intestine not only becomes obstructed and dilated, but blood flow to the intestine itself is compromised, raising the risk of the bowel becoming necrotic. As noted on the illustration, in strangulated obstruction, this closed area where blood flow and contents are trapped is called a closed loop. When a closed loop exists, emergency surgery is necessary to restore the small intestine to its proper position. Otherwise, inadequate blood flow will cause it to become necrotic and rupture, leading to peritonitis or sepsis and potentially death. Thus, when interpreting imaging for ileus, once you identify ileus, you must localize the obstruction and assess the cause in the presence of a closed loop in order to determine whether emergency surgery is required. That's the key to saving lives. Let's analyze this case in more detail. At this point, we've identified diffuse small intestine dilatation, ileus, and a beak sign in the pelvic region where the small intestine suddenly narrows, suggesting obstruction there. Where does this intestinal obstruction fall within the classification chart? Here's the answer. It's simple obstruction due to adhesions. If this were strangulated obstruction, you would see findings such as increased signal in the fat from inflammation triggered by severe constriction, or signs of ischemia in the intestinal wall from compressed blood vessels. Additionally, you might see distinct appearances, such as multiple beak signs or a clear closed loop. However, in this case, none of those findings are present around the obstruction site. There is no strong signal increase suggesting inflammation, and there is no sign of ischemia, such as the small intestine failing to enhance with contrast. It appears to be simply a single point where the intestine narrows abruptly, causing obstruction and ileus. Let's confirm on the coronal images. Again, the findings are few, and it looks like a localized narrowing causing obstruction. In such cases, we can identify it as a simple obstruction, not a strangulated one. Causes of localized obstruction, like a simple obstruction, include adhesions or intraluminal causes like food or cancer. But in this case, it doesn't appear that something is lodged inside, nor did cancer cause the wall to bulge and occlude the lumen. Instead, because the small intestine suddenly narrows and displays a beak sign, we can infer that it's likely adhesive obstruction, where the bowel has adhered to some other area and become tight there. When suspecting adhesive obstruction, in addition to imaging findings, it's crucial to ask, has there been prior surgery in that area? Has the patient experienced repeated enteritis there? These perspectives are important. In particular, regions with a surgical history tend to form more adhesions during healing, making them common sites for adhesive ileus. Incidentally, imaging usually doesn't reveal precisely what the bowel is attached to. This isn't a matter of experience. Images simply often can't show it. If the small intestine is stuck to the abdominal wall or another organ, that might be visible. But there are membranes and fibrous bands that don't appear on imaging. The bowel might adhere to them as well. Rather than identifying these connections on images, at best you can infer something like, given the anatomy, it's probably adhered to that structure around here. You only learn the actual answer during surgery. But that level of detail isn't crucial. What's important from the imaging is to identify the obstruction site and evaluate for a closed loop or ischemia. If you can do that, you've nailed it. Since this is adhesive ileus, there's little risk of the small intestine becoming ischemic and necrotic. Although the passage disturbance requires treatment, surgery is often unnecessary. With intravenous nourishment and decompression of the intestinal contents using an ileus tube, the obstruction will gradually resolve and heal. How is this? This is how we read images of ileus and intestinal obstruction. In this case, the findings were minimal because it was simple obstruction due to adhesions. But in strangulated obstruction, there are many different signs to discuss. We'll go through those one by one when we encounter a strangulated obstruction case.
Introducing Okiraku Scroll Viewer. Have you ever wanted to scroll through the scans yourself while watching imaging videos? Once you hear the answer, it sounds easy, but when you try to interpret the images on your own, it can be quite challenging. Still, if you form your own differential and then check the answer, your reading skills improve dramatically. Watching someone else scroll makes it hard to read. That's why we created Okiraku Scroll Viewer, a specialized training site for imaging interpretation. Just like in a real clinical setting, you can scroll through the images freely. It includes various cases and their answers. By scrolling yourself, making your own diagnosis, and then checking the answer before reviewing the images again, you're guaranteed to get better at reading scans. If you're interested, please jump to the link in the description and try scrolling for yourself. You can use it on both your phone and your computer. See you in the next case. Until then.